Are we going to have one day a test where you come to me and I don't know whether you have maybe depression or bipolar disorder, and I do a genomic or a genetic test and I'm able to say, aha, you have bipolar disorder, you don't have depression. Or somebody who is exhibiting some psychotic symptoms, and I think maybe they have schizophrenia, maybe they don't have schizophrenia, and to commit them to that devastating diagnosis. And then you could be able to do a genetic test, a genomic test, and you would say, aha, you have schizophrenia. Hello, and welcome to our new episode of Unmuted, the Diaries of the Virtual Psychiatrist. I am your host, Dr. Muhammad Ali Rifai, and today I'm deeply excited to guide you through the fascinating world of psychiatric genomics. Let's cut to the chase. We're going to be talking about the essence of life, and we're going to be talking about an area that blends our very essence with the promise of precision psychiatry. So let's begin. What is genomics? Genomics is the study of an organism's complete set of DNA, the deoxyribonucleic acid. It includes all of our genes. Those are those little things that are inside the nuclei in our cells. And genes carry the blueprint of life, instructing our bodies how to develop and how to function. And each gene consists of a DNA sequence, and small variations in those DNA sequences that are known as genomic polymorphisms can really significantly affect how we respond to illness, how we are susceptible to psychiatric illness or other medical illnesses, and how we respond to medications, or how even our genes protect us from life stressors and the consequences of life stressors and how those exhibit. I vividly recall in my early days in my training in psychiatry, I was awarded the American Psychiatric Association Janssen Scholarship on Research in Severe Mental Illness. And that enabled me to expand my studies. When I was doing my residency in internal medicine and psychiatry, I expanded my studies on psychiatric genomics. At that time, it was exhilarating. It was a time where the potential for genomics really felt infinite. And at that time, this is the year 2000, 2001, the landmark Human Genome Project. We didn't know our DNA. We were mapping our DNA all along, trying to figure out what do we have. And initially, in my earlier days in medical school, we thought that we had maybe millions of genes, hundreds of thousands of genes. But actually, the Human Genome Project gave us some answers at that time. We discovered that we only had maybe 20 to 30,000 genes. We were thinking genes in the millions. And shockingly, we thought that there were a lot of areas that we thought that those were silent regions of our genome. And we called them at that time, this is the Human Genome Project in the early 2000s, we called them junk DNA. Well, junk did we know? We now know that these areas profoundly affect the activities of our genes and affect our health. So fast forward to 2025 now, we know vast amount of information. We've studied the genome, but we're still far away from being able to predict illness. But today, as I take you through that journey, I want to draw from my own personal research. I'm telling you my own experience, having been a participant and a witness at the induction of the Human Research Project, a Human Genome Project at the National Institute of Health, and how the human genome was discovered and fully mapped in my time at the National Institute of Mental Health. And I want to give you my own personal research looking at the origin and susceptibility to depression and anxiety, and my experience in psychiatric genomics, and how these days we utilize psychiatric genomics and genomic testing to tell us how we are able to manage our patients. Genomics are impacting patient care. So let's delve into this deeper. So let's delve into this deeper. Bipolar disorder often ran in families. For instance, in 1940s, Franz Kaliman demonstrated that schizophrenia had really a high heritability rate through twin studies. Today, however, we understand that there is no single gene that determines psychiatric illness. Rather, it is a complex interplay between many genes and environmental factors and issues related to stress, to hormones, to diet, to the environment. I've spent many years myself investigating how small genetic variations influence psychiatric disease. I have multiple papers where I investigated susceptibility toward depression, and we documented multiple genetic variabilities in multiple genes, some of which related to the hormone and substance interferon that fights infections and affects bodily functions, how interferon variations in the gene coding for interferon variation in that affects susceptibility toward depression. We now know that psychiatric genomics also give us a new lens to comprehend why some patients respond remarkably well to certain medications while others suffer from adverse effects, or maybe sometimes they get very minimal benefit from these medications. Now let's consider this. Our genome vary significantly, but we think that between one human and another, the variation and the differences are very little. What differentiate one person from another, we're talking about less than 1% of variations in the genome. And we know that tiny differences, what we call SNPs, single nucleotide polymorphism, so just one change in the base pairs in the DNA can dramatically impact the efficacy and tolerability of some medications. So you would give the same medication to different individuals if they have different SNPs in the same gene that gets affected by this medication. If they have different SNP polymorphisms, these individuals will respond differently to the same medications. There's been a lot of commercial activity trying to understand and harness some of these insights and offer some genetic tests that guide clinicians toward prescribing, this is specifically in psychiatry, prescribing the most effective and the safest medication that would help an individual achieve remission from their psychiatric illness. So we are not there yet where we would be able to do a genetic test, a genomic test, and would tell somebody whether they're more likely to have this disorder versus that disorder. Specifically, for example, whether it's depression, anxiety, or bipolar disorder, or even tell that they are susceptible to that disease, something that would give us a strong case for the diagnosis. We are able to do testing where we would do genomic testing and tell the patient that they are likely to be able to stay on this medication uninterrupted with minimal adverse effects at least. Now, currently also, this utilization of psychiatric genomics to tell the adverse effects of psychotropic medication is really very crucial. Despite these advances, we remain many, many years away from fully harnessing that genetic and genomic information to accurately diagnose psychiatric illness. Are we going to have one day a test where you come to me and I don't know whether you have maybe depression or bipolar disorder, and I do a genomic or a genetic test and I'm able to say, aha, you have bipolar disorder, you don't have depression. Or somebody who's exhibiting some psychotic symptoms, and I think maybe they have schizophrenia, maybe they don't have schizophrenia, and to commit them to that devastating diagnosis. And then you could be able to do a genetic test, a genomic test, and you would say, aha, you have schizophrenia. Psychiatric disorders are exceptionally complex, and they're influenced by an intricate interplay of multiple genes interacting with each other. And we talked about the environmental factor and the psychological factors. So this complexity really means that purely genomic or genetic diagnostic testing at this time really is beyond our reach. And we think maybe it'll be at least a decade for us to be there. We are doing significant research. We are doing what we call genome-wide scans to see if maybe we can identify those markers that would help us with psychiatric diagnoses. However, we know now that genomic testing has become really invaluable in mitigating the adverse effects associated with psychotropic medications. As I told you early on in my career, I was at the National Institute of Mental Health, coinciding with the completion of the Human Genome Project, but I also was lucky to collaborate with folks at the Mayo Clinic. And in 2004, I attended this big conference, the fourth Genomic Mayo Clinic Conference, and it was after the completion of the Human Genome Project, and it was led by the chairman of psychiatry at the Mayo Clinic, the late Dr. David Mrazek, who later on developed this GeneSight test to test for psychiatric susceptibility and susceptibility to adverse effects of medications. Dr. Mrazek, who passed in 2015, developed this specific testing for genes such as the cytochrome P450, which metabolizes the majority of psychotropic medications. And variants within those genes really determine how a patient metabolizes the majority of psychotropic medications. So, for example, in patients who have genomic polymorphisms that make them have a rapid metabolism, because not all patients have the same rate of metabolism of medications. So those who are identified as having genetic variations, polymorphisms, SNPs, that offer a rapid metabolic activity for the enzyme cytochrome P450 with its different variants. And the main one is the cytochrome P452D6. Those who have a rapid metabolism may require higher dosages to achieve the same effect of medications. While a patient with a slower metabolism, with a slower metabolic rate related to a different SNP, to different genetic polymorphisms in their enzymes, the cytochrome P452D6, may require lower doses, even lower doses than the standard dosing. And genomic testing can really help clinicians and identify beforehand these variations, these polymorphisms, and will enable us to anticipate whether the person will require a regular dose, a higher dose, or a lower than normal dose to avoid adverse effects that are associated with higher level of medications that may lead to significant side effects. And we know in psychiatric medications, side effects would include gastrointestinal side effects, as well as other significant side effects. And sometimes even some of the side effects would be fatal, such as the serotonin syndrome. Psychiatric genomics can also help us identify patients who are at heightened risk for severe adverse reactions of medications. We give a medication that is called clozapine, and there is some genomic testing that would foretell and would tell us beforehand whether a person is at risk for developing a near fatal adverse effect of this medication, of this essential medication for treatment of schizophrenia. This adverse effect is called drug-induced agranulocytosis, so a lowering of the white blood cells that sometimes could be fatal if not caught. So we may be able to anticipate whether a person is susceptible for that adverse effects. There are also other genomic variations and genomic markers, such as the variants in the HLA regions that have been linked to adverse effects and reactions to medications. Throughout my career, my clinical experience really has taught me and underscored the profound benefits of employing these genomic factors and genomic testing to manage psychotropic medications and to enable patients to be able to tolerate these psychotropic medications to give them the best possible chance to achieve remission from their psychiatric illness. We use a test called GeneSight that has allowed us to help patients who have previously suffered from significant adverse effects to medications. And they were able to choose different psychotropic medications that have enabled them to feel that they can continue on their medication and be able to achieve remission from their psychiatric illness. These targeted approaches have really transformed patient care and really improved medication adherence, enabling people to have an overall better quality of life. Genomic testing has also offered us insights into the risks of medication-induced metabolic syndrome. For example, there are a lot of psychotropic medications, such as antidepressants and mood stabilizers, that are associated with metabolic adverse effects. For example, weight gain, the possibility of lipid abnormalities, the development of diabetes. And these adverse effects happen in a lot of psychotropic medications. We now know that genetic predispositions that are identified beforehand through genomic testing can really inform us about who is at risk for weight gain with psychotropic medications and or for developing adverse effects from these medications, gaining weight, developing diabetes, having hyperlipidemia, maybe being at risk for heart attacks, and how we can avoid some of these harmful adverse effects to enable individuals to take their medications safely and not develop adverse effects. Also, people know that a lot of patients who receive psychiatric medications are taking multiple psychiatric medications. So we face the issue of polypharmacy, and we sometimes have patients who are taking 3 to 4 to 5 psychotropic medications to enable better resolution of their psychiatric symptoms. So we have polypharmacy. So these genomic tests can help us identify drug-drug interactions and whether these drug-drug interactions interact also with the genomic polymorphisms, the different SNPs, and how those interactions can affect the development of adverse effects. So by developing an algorithmic combinatorial approach, some of these tests, when combined together, can enable us to treat patients with a combination of psychotropic medications safely. And doctors can really avoid the sequential trial and error approach that frequently sometimes leads to unnecessary polypharmacy and can lead to adverse effects and patient suffering because patients have to try multiple medications until they're able to reach the medication that works for them. Importantly also, some of these genes that we find sometimes can inform us about whether a person is able to be on multiple medications at the same time. Again, I see that we are going to be able in the future to do genomic testing to tell us the diagnosis, do a test and be able to tell people what diagnosis they have. However, the complexity of psychiatric disorders with different, diverse genomic and environmental interactions really present significant challenges. But we think that with the advent of complex genomic testing, higher computational power, and even AI, we may be able to one day be able to do one test and tell the person whether they have a psychiatric illness, and the increase in the accuracy of these genomic tools. Indeed, we know that psychiatric genomics has really shown the overlap among various disorders. So an individual may have, for example, depression and anxiety and post-traumatic stress disorder and obsessive-compulsive disorder, and that overlap sometimes creates significant challenges to psychiatrists who treat these patients. But we continue to prioritize that medications can be essential and life-saving to individuals who have severe psychiatric illness, and that we have the duty to be able to utilize these psychiatric genomics to help these patients. We've also had other uses for these genomic testings. In the previous episode, we had talked about a treatment called transcranial magnetic stimulation and how this medication-free treatment by giving magnetic waves to help depression, anxiety, bipolar disorder, post-traumatic stress disorder, and drug use disorders, how we are able to treat some of these illnesses. And sometimes the genomic tests will tell us that some individuals will probably not have good luck with many psychotropic medications or most of the psychotropic medications. And in those situations, we may actually know that psychotropic medications may not be a good choice for this patient, and we can early on implement and utilize transcranial magnetic stimulation, the treatment that we talked about in the previous episode. So I think that these genomic tests have been very, very helpful for us, especially in these scenarios. Looking forward, I think that the future of psychiatric genomics is luminous. We are rapidly approaching a reality where genomic data become really integral to everyday clinical decision. It reduces the suffering, it enhances the quality of life, and I foresee that psychiatric genomics will not only improve individual outcomes, but will have a fundamental impact in reshaping the landscape of mental health care. We're going to be able to tell who's at risk for a certain psychiatric illness, and maybe they will work on their environmental factors, on their metabolic issues, on their stress level, not to develop the psychiatric illness that they're susceptible to. So we have a good work ahead of us to be able to actually not just treat psychiatric illness, but potentially prevent psychiatric illness. As we close today, let us remain hopeful and engaged that the hope and that the future of genomics, the study of our gene, the study of our DNA, reminds us that it is very difficult to understand ourselves deeply, but we are getting there. At our deep genetic core, we are a vulnerable race. We humans are at risk for psychiatric adverse effects to medications that can help these illnesses, and we need to be able to maintain our quality of life with genomic testing that would help us prescribe medications with the minimal adverse effects and can help improve the quality of life of people who are suffering with psychiatric illness. Let us embrace the immense potential ahead, driven by compassion, by science, and by a relentless commitment to healing. Thank you very much for joining me on this profound journey today, talking about psychiatric genomics. And I know that the future holds bright things for us in terms of being able to predict the development of psychiatric illness, to predict who is susceptible for psychiatric illness, develop and devise prophylactic approaches to psychiatric illness. And when the psychiatric illness develops, we may be able to choose medications that match the psychiatric illness and that produce the best possible outcomes for our patients with the minimal adverse effects. Wishing you until next time, health, insight, and peace. I'm Dr. Muhammad Ali Rafai, unmuted, the virtual psychiatrist.